وبنفس الوقت صباح النور لكل الزملاء اللي عم يتبعونا من القارتين الأمريكية الشمالية.
We lost you.
I think we've lost Dr. Yusuf, but I want to welcome everyone to this important webinar. We'll have Dr. Yusuf with us very shortly to open up the meeting.
Wally, how are you? If you
Good,
can start with the Naib first.
Okay, I will do that. I want to welcome everyone around the world, and in particular in Lebanon, to this important webinar. We've just lost Dr. Yusuf Bakhosh, but he'll come back with us. In this important series, it's an honor and privilege to have with us the president of the Lebanese Order of Physicians, Dr. Sharaf Abi Sharaf, to open the meeting. Dr. Sharaf.
أنا بدي أشكركم جميعا وخاصة جمعية الإلما ولمنظمي هاللقاء دكتور وليد أحمر، دكتور بخاش، دكتور مدونة مطر، وللمحاضرين دكتور عبد الرحمن البزري، دكتور نادين رفايل، بروفيسور إسبر كاليس من البرازيل، دكتور سمر عجيمي من ملبورن. طبعا الكوفيد 19 بعد ما انتهى وعلى ما يبدو مجبورين نتعايش معه بالوقاية باللقاح وبالعلاج، وفي أسئلة كتيرة بتأمل إنه نحصل عليها بهاللقاء هذا، خاصة بعد ما قطعنا سنتين مع الكوفيد، وأكيد في أشياء كتيرة بعد ما عنا أجوبة عليها. ولكن عندي تمني من الأكثر من أطباء بلبنان عم يتصلوا فيي عم يطلبوا، وهيدي كمان سؤال موجه بالدرجة الأولى بعتقد لدكتور عبد الرحمن، إنه التلقيح ينفتح أكثر ولكن بطريقة منظمة أكيد، وخاصة إنه عرفت إنه في عنا ما يكفي من اللقاحات، وعدد الملقحين لحد هلأ بلبنان مع الأسف بعده نسبيا قليل، ما بعرف إذا وصل لل 35%، وهناك طلب زائد من الأطباء خاصة إنه يحصلوا على الجرعة الثالثة بأسرع وقت ممكن، وللأشخاص اللي هن فوق عمر 60 أو عم بيعانوا من أمراض مزمنة. بتأمل من دكتور بزري نقدر ناخذ جوابات عليها، يعطينا توضيحات يسهلنا هالأمور. وبطبيعة الحال برجع بكرر شكري للإلما بالدرجة الأولى اللي عم بتنظم هالاجتماعات هيدي، واللي هي جدا مفيدة لإلنا تبادل الخبرات، ونضل على بينة من وين صرنا بالأمور العلمية والليلة خاصة فيما يتعلق بالكوفيد 19. وشكرا.
So أنا بدي أعتذر لأنه صار في عندي problem of connection. So دكتور شرف أبو شرف، شكرا على هذه المقدمة والكلمة. And now I have the great honor and the pleasure to introduce Dr. Walid Ahmar. Dr. Walid is a cardiologist from Lebanese descent. He is established in Melbourne, Australia. He is one of the co-founders of the ILMA, International Lebanese Medical Association, and he is its current president. Dr. Ahmar, the floor is yours. Tfaddal.
Thank you, Dr. Yusuf. Good evening. On behalf of the International Lebanese Medical Association, or ILMA, I want to welcome all our Lebanese physicians, health professionals, and medical students, both within Lebanon and throughout the world, to this joint educational webinar with the Lebanese Order of Physicians. I also welcome our ILMA colleagues throughout the world. Growing our knowledge base is important, not only for our continued development as physicians, but also in delivering the best level of care to our patients. We can all learn from each other in multiple ways. ILMA is excited by its collaboration with the Lebanese Order of Physicians in these educational webinar series. We want to partner with our Lebanese colleagues to advance our knowledge base and to establish collaborative medical partnerships, including in education and research. I am proud of all our Lebanese physicians, both internationally and within Lebanon. ILMA wants to bring the best of the international world of medicine to Lebanon. I want to thank the President of the Lebanese Order of Physicians, Dr. Sharaf Abi Sharaf, for all his wonderful efforts in supporting this educational webinar collaboration. I also want to thank Dr. Yusuf Bakhosh and the ILMA LLP Education Committee for working together to bring this webinar and future webinars to fruition. I hope you enjoy and learn from tonight's COVID-19 Breaking the Chain webinar. Thank you. Dr. Yusuf, you need to unmute, Dr. Yusuf.
So thank you, Dr. Ahmar, for this introduction and for this speech. So اسمحوا لي هلا أنا أحكي كلمة صغيرة. كوني ساهمت بتنظيم هذه الحلقة وكوني أمين سر للجنة التثقيف الطبي المستمر بنقابة أطباء لبنان ببيروت. مهنة الطب تهدف وتتمحور حول معالجة المريض، ولكن هذه المهنة السامية ما بتكتمل إلا إذا اقترنت بمسار تثقيفي وتعليمي ببادر فيه الطبيب لحتى يطور محصوله العلمي ويبقى على اطلاع على آخر المستجدات والابتكارات العلمية بهدف أنه يقدمها إلى مريضه. إذا كان هذا التثقيف الطبي المستمر هو واجب على كل طبيب، كلنا اليوم بنعرف أنه بظل هيدي الأزمات اللي عم نعيشها صار كتير صعب على زملائنا أنه يسافروا أو يشاركوا بمؤتمرات لأسباب مادية بحتة. فأجت هذه المبادرة وهذه الحلقات العلمية بالوقت المناسب لحتى تسمح لكل الأطباء اللبنانيين وعلى مساحة الوطن أنه يضلوا ويحافظوا على مستواهم العلمي بهدف خدمة المريض والمجتمع. Maintenant, j'ai le grand honneur et le plaisir d'introduire le docteur Madonna Matar, qui est spécialiste en médecine interne et en maladies infectieuses. Elle est la présidente de la Société libanaise de maladies infectieuses. Docteur Matar, la parole est à vous.
Merci. I want to thank Dr. Walid Ahmar first, the head of ILMA, for this initiative. And I thanks as well the President Abu Sharaf and Dr. Bakhosh for their collaboration. I welcome all of you who have joined us tonight. You know, we are almost 2 years since the pandemic has started, and we have learned lots of new information from COVID-19 pandemic, and we are still learning every day. And you have been through many international COVID webinars so far, but what is special today is the fact that we have excellent speakers tonight who will be discussing updates on our national challenges and data, vaccination, including the booster dose, new therapeutic options, and how to manage the immunological part of the COVID storm. And remember that the best way to fight the pandemic so far is by joining our forces to limit the viral transmission. Vaccinating all the population as quickly as we can is crucial. And what is equally critical is continuing with the personal protective behaviors and public health measures to reduce the transmission. Also, having available and efficacious treatment are urgently needed. We're gonna start tonight with Dr. Abdulrahman Bizri, who is a brilliant infectious disease physician from the AUB. Dr. Bizri is leading the National COVID-19 Vaccine Committee He has done a tremendous effort to provide us with scientific guidelines and recommendations regarding the strategic plan of COVID vaccine deployment in Lebanon. And we as colleagues are proud of him. Dr. Bizri is going to discuss tonight the national COVID-19 challenges and future perspective. Dr. Bizri, the floor is yours.
Thank you, Madonna, and good morning, good evening. I don't know what to say. It's for everybody. Naib Abu Sharaf, Dr. Ahmar, it's always a pleasure to see you again. Dr. Bakhash and Madonna, thank you for your efforts and for all of our colleagues. If I may share the screen, if possible. Do you see my slides, please? Okay, so if you can see my slides, then it's fine. I'll be talking about the COVID-19 response in Lebanon, the challenges and the future perspectives. You know that COVID-19 is not the only epidemic that Lebanon has faced in recent times. We know that the world, including Lebanon, has been threatened by several epidemics. Some of them were really very scary, such as the Ebola, the SARS, the Zika, and the other viruses, but only few epidemics really touched Lebanon in a very strong way, like what happened to COVID. So COVID really had left its strong burden on Lebanon. We know that Lebanon have experienced the HIV/AIDS epidemic or pandemic in the past, and as a result, we have a very active Lebanese AIDS Society and National AIDS Program. We probably had our H1N1 problem with the swine flu initially, and this is why we have the National Communicable Disease Committee in Lebanon in order to help the Ministry of Health to formulate response for epidemics. But we know that Lebanon has also experienced several local outbreaks, which were either attributed to Lebanese problems, either post-war era, like what happened with the Vibrio cholerae problem, or like what happened with the following the Syrian crisis with the Leishmania, when we had Leishmania in Lebanon after so many years of losing it. Measles and mumps outbreaks do appear on periodic basis in Lebanon, as well as recently because of the drop in the quality of our basic infrastructure, we start having an outbreak of hepatitis A. However, all of these cannot be measured with the COVID-19 pandemic, because the COVID-19 pandemic became a national problem. It did not only become a public health problem, but it became a national and a problem. And this is why we had a lot of committees. We had the National Crisis Multi-Ministerial Committee, and including the National Interministerial Crisis Task Force. The Ministry of Public Health had its own committees, the Communicable Disease Committee, the National COVID Vaccine Committee, the Scientific and Technical Committee. You have to remember that in Lebanon, we don't have an equivalent to the FDA. So we had to approve the new vaccines, give them EUA in a quite different way, and we have the Joint Monitoring Coordination Committee. So this is why we had, at least at the early days of the COVID and during some of its peak, we had what you call some sort of lack of coordination, appropriate coordination between various intradepartmental committees. However, the most crucial were those affiliated with the Ministry of Public Health. We have the Communicable Disease Committee, which was historically present before, and it became officially present in 2009. It has a consultative role. It addresses all communicable diseases. It's completely made out of, from private and academic sector. All are non-paid. They provide advice to the Ministry of Health. And they were really almost meeting twice or three times on regular basis, on weekly basis, for the sake of COVID advice and COVID response. We have the National COVID Vaccine Committee that I also chair, is established recently in 2020. It has multidisciplinary experts. The objective is to put a vaccine plan, to implement it, to monitor it, and to really upgrade it when necessary. And it has several subcommittees that were really established from that committee. So what happened when COVID really came to Lebanon? What's so peculiar about Lebanon at that time? You have to remember that the timing and the overlapping events were not really quite friendly to Lebanon, because at that time we had the October 17 uprising. Following the October 17 uprising, there was really a total collapse in most of the departments in Lebanon, and there was a total collapse in the economic and in the monetary system. So this really, so the COVID came really at a very bad time to Lebanon, and this is where we probably, the public sector response had really to be boosted, to be really beefed up. The private sector were initially hesitant to enroll in the fight against COVID, yet finally they played a very important role, especially at the level of academic institutions and university hospitals. The international response was really quite friendly to Lebanon and quite supportive. Lebanon is rich with non-governmental organizations that also contributed, and of course, we'll tell you what is our current status and what are the future challenges. If you remember that COVID came during the October uprising, so with the October 17 uprising, we had really our, following that few months, we had our first case of COVID. Then we started seeing more cases, so we had to close educational establishment, then touristic establishment. Then we went into complete curfew and health emergency state. And then we had to declare a national curfew. And this is where probably the Lebanese economy went into really severe depression. So we implemented non-pharmacological interventions. But the non-pharmacological interventions were very difficult to implement because they are non-commensurate with the human social nature, and we know that the Lebanese people are quite sociable. With the economic consequences are devastating and were devastating to Lebanon. The social repercussions were devastating. The educational concerns are high. Now we are entering our third year without really having true schooling system or opening or functioning well. The cultural ramifications, we had absent of any cultural activity, the physical effort also, and the neurological and psychological effects were tremendous on everybody and definitely in Lebanon. In order to add further insult to injury, we had the Beirut port blast, which was really a catastrophic blast at that time, and it destroyed a significant component of our healthcare sector. This healthcare sector that was really quite indulged in fighting the COVID pandemic. So this is why people thought that the healthcare system is like a phoenix. It has been gone into almost next to near ashes, and it's now being revived again, even against all the odds. So if you look at the COVID distribution of cases in Lebanon, it's very interesting because if you look at the number of cases since we just recorded our first case, and after each peak, you could really find what you call some sort of an event. The port of Beirut explosion here, and you can see the peak of events. Then we had probably the worst of all waves of COVID-19 in Lebanon following the Christmas and the New Year, the season holiday, where a lot of Lebanese came to Lebanon, and all the restrictions will drop. And this is why we have seen really a significant wave of COVID-19 cases. Mind you, at that time, the healthcare system was still relatively intact. And now we are fearing that if we really repeat such a similar way with the current situation of the healthcare system, we may not be able to cope with the repercussions. Then we had our summer season, and you know that this is a milder peak here. I think this is partly due to the fact that our vaccination and our herd immunity coverage rates were becoming much better. If you look at the number of total cases in Lebanon, you will find that the rise in Lebanon was not really a very steep rise. And this, despite that we had several waves, The rise was not really very steep, and this allowed us time to prepare the public sector's hospitals, to prepare the private hospitals, to have more ICU beds, to train more staff to deal with COVID cases and so on. And this is why the impact, despite our very difficult and strict conditions, the impact was relatively less than what we expected. If you look at our current now status, we know that we are seeing most of the cases of COVID ranging between age 10 and 50. And these are the age groups that are not still yet fully vaccinated. This is where we still have low vaccination rate here, because initially we were targeting the elderly people. And now, since the people, those between 30 and 50 were supposed to take AstraZeneca, and they were quite hesitant to take they were hesitant to take AstraZeneca. They refused to take the vaccine. Now we are giving Pfizer to this age group, and we are giving Pfizer to this age group, and hopefully we'll have more vaccine acceptance. And if you look at the cases reported per vaccination, you will know that around 85% of the cases are in those not vaccinated or fully vaccinated. So this is good evidence that vaccine worked nicely in Lebanon. And if you look at the cases with mortality, you will know that mortality is around 1% in those who were vaccinated, and in more than 99% in those who were not fully vaccinated. And this is what you can see here, the new mortality cases. It is mainly we are seeing some mortality in the unvaccinated group. So this is why it was imperative to have a COVID vaccine plan. First of all, because the disease has a very high burden. We have very limited success in our pharmacological intervention. It was very difficult to implement them in a country such as Lebanon. We have a virus with high infectivity, difficult to attain and costly herd immunity. We cannot rely on natural infection to achieve herd immunity. And finally, the emergence of variants. So this is why we had what you call the COVID vaccination plan. And our plan worked relatively very well, because so far we have managed to administer around 3.5 million doses. So around 44%, we have vaccine cover, 34% vaccine coverage for those above 12 years of age, and around 30% for the second dose coverage. Mind you, these statistics are misleading. Why they are misleading? Because so far we don't have a common denominator in Lebanon. The common denominator that we have calculated these numbers are 6.8 million. Now we are correcting our common denominator, and we believe that the number of people residing in the country is not 6.8. We are talking about Lebanese and non-Lebanese. It's around 5.5 million. So if we correct this, we will probably reach a much higher vaccination coverage rate. The most acceptable vaccine in Lebanon was the Pfizer vaccine. However, in Lebanon, we have other type of vaccination or vaccination platforms other than the government. We have the private sector, which coordinates with the government. We have the army and other security forces that coordinate with the government. We have donations mainly from friendly countries. I can tell you soon that we're going to have a French and American donation. They are going to be very big donations. We have political vaccines in Lebanon, and we have a lot of Lebanese who reside in Lebanon and have received their vaccines outside the country. The national COVID vaccination plan, when it was put into action, it really had some criteria to abide to. First of all, it should be a free public vaccine for all. So all vaccines bought by the government are provided for free. The process is quite transparent and equal, because our priorities are mainly those of age, profession, and medical condition. We are promoting choice. We do not forcing people to get vaccinated, and we have a very good vaccine quality in the country. We have standard operating procedure for all vaccine delivery, whether delivered at vaccine centers or by ambulatory services. We have emergency use authorization given to all utilized vaccine. And we know that the aim of our vaccination, the target of our vaccination plan is to protect individuals, to achieve high levels of herd immunity, to reignite our economic cycle, to open school and colleges, mobility and travel in and out the country. And I can tell you from now that the United Kingdom and the European Union has approved the Lebanese QR code, and Lebanese can travel freely now to United Kingdom and to EU. Normalization of life. So what was really the basic challenge for that is to get a decent common denominator. The decent common denominator now, we believe that it's going to be somewhere between 5.5 to 5.8 million instead 6.8 million, and this is more reassuring. So we have 4 types of vaccines approved in Lebanon: the Pfizer-BioNTech, the most widely used, the AstraZeneca, the Sputnik 5, which is of limited use, and the Sinopharm, which is widely used among the army. And we are going to get a very large donations to the Palestinians and from the Chinese government. Now Moderna has applied for emergency use authorization in Lebanon, and Johnson & Johnson has also applied because we're going to get them through donations. As the Naib Abu Sharaf has mentioned, yes, we're going to get very large amount of vaccines, and we have large amounts of vaccines. So the problem of vaccine amount is not an issue, it is the problem of vaccine acceptance in the country. So this is why we have decided to go through 2 tracks. First of all, to encourage people who had really hesitancy towards the vaccine, to encourage them to receive the vaccine. And second, to start with the 3rd booster dose. So this is why we came out, our committee, with the new recommendation. The 3rd dose recommendation was issued in Lebanon 3 weeks ago. First of all, we divided them into 3 categories: extension of the initial series. Those who received Sinopharm or any inactivated type of vaccine must and should have a 3rd dose. Otherwise, they will not get a vaccination certificate, because we know that Sinopharm in 2 doses is not enough. Vaccine completion, those who are immunocompromised or are taking immunocompromising medications should test their antibody level and can receive a 3rd dose as completion after 1 month of the 2nd dose. And the 3rd dose, which is the booster dose, we are starting the booster dose for elderly people. We are going down gradually by age, by profession. Many of the medical centers are calling on their doctors to receive the vaccine 3rd dose, and later we are going to go by clinical conditions. We said that the booster dose can be from the same vaccine or from different vaccine, in order to encourage all Lebanese and those residing in Lebanon to take more vaccines because of the hesitancy. And this is data produced by our group in Lebanon, where we have showed, interestingly, that those who have really received 2 Sinopharm doses, those who have received 2 Sinopharm doses and received a booster dose from Pfizer will really fare much better than those who have really received 2 doses of Pfizer. So this tells you that we can mix and match vaccines, even giving a 3rd dose from a different vaccine, and this is what we are doing in Lebanon. However, we have a problem. We have vaccine acceptance is very low in many Lebanese areas, mainly in the north and in Bekaa, in the south and in the Nabatiya region. It is very high in Beirut and in Mount Lebanon. So although Beirut and Mount Lebanon has the largest concentration of population, yet this leaves a lot of Lebanese regions with low vaccination coverage. Another challenge for us is the refugee challenge. We know that Lebanon is the country with the highest number of refugees per capita in the world. We believe that represent at least 30% of the population, and they are at risk of communicable diseases. However, the problem is that they were hesitant towards vaccine. Now we are working with the UNHCR, with the Syrian and the UNRWA, with the Palestinians in order to encourage them. And recently now we know that when we started giving vaccine between 12 to 15 years of age to refugees, we have 150,000 Syrians were registered to receive the vaccine in Lebanon, Pfizer, and this is really very good news. Now we are encouraging them, and we hope that the children will encourage their parents to receive the vaccine. We are creating mobile vaccine units to go into their concentration area in order to provide the vaccine with them. We have another problem in Lebanon is the foreign labor force. Nobody knows how many still in Lebanon, but we know that at least half of them are illegally present. We are encouraging them to get the vaccine despite of their illegal status. And recently we succeeded with one of their embassies. We had around 50,000 from one embassy. We are coordinating with them to receive AstraZeneca, and we hope we are encouraging them to receive vaccine. We believe that they are probably somewhere between 300 to 400,000 foreign labor force still residing in Lebanon, and we need to vaccinate them because they can be source of transmission later. So what are the current challenges that face the communicable disease situation in Lebanon? We know that COVID has really affected the situation in Lebanon, and we know that many communicable diseases has suffered very badly from the COVID, because in Lebanon, unfortunately, most of the Lebanese Ministry of Public Health were switched from their normal activity to do COVID surveillance. And this is why we have lost a lot of surveillance activity and a lot of immunization activity against communicable diseases. And this is data produced by our group also to show that, for example, we have dropped in our childhood measles vaccination 40%, and you can see that all across that childhood routine vaccination drop was significant during the COVID area, because either parents were hesitant to come or we were not able to provide them with the necessary vaccines. So the future challenges are that we are short of staff at the Lebanese Ministry of Health, despite the fact that we are volunteering with them. We have very limited resources, and Lebanon relies heavily on donors, World Bank, WHO, and others. We have neglect of other communicable diseases, and we have multitude of players in our response. So we have a lot of suboptimal coordination, which the Lebanese government, because it's so weak and failed to coordinate this response. We have still high hesitancy and resilience against vaccine. So this is why we are going for a mix and match in order to encourage people to take AstraZeneca and Pfizer instead of AstraZeneca alone. We have low registration among refugees and migrant workers and peripheral area. We are so far keeping our cold chain very well, but unfortunately, given the situation of electricity and the fuel in Lebanon, I don't know for how long we can keep that chain going. So far, it's fantastic. We have no problem. We have a lot of antiviral agents coming to Lebanon, but we cannot have them because simply the World Bank is not opening any credit. So all the Lebanese population will be deprived of new antivirals and the new monoclonal antibodies. We know that we have a lot of vaccine stocks here. But yet our vaccination rate can be improved because we have a problem with acceptance and we have what we call a problem with delivery. Why? Because we have vaccine fatigue in our centers. Unfortunately, when we initially produced the plan, we decided to give some sort of payback for those who were delivering vaccine at delivery centers. But for reasons we don't know, the Ministry of Public Health decided to remove this money. So now we know that many vaccine centers are working under what you call less than their own half of their capacity because they cannot afford to use their staff for vaccination and for routine activity. We have really very difficult challenge in keeping the balance between normalization of lifestyle and life cycle in Lebanon. And of course, soon the Lebanese will start worrying about vaccinating children between 5 to 12 years of age. We have enough vaccine doses, but we really need to retrain our staff how to give the vaccine for this young group of generation. Unfortunately, some of the problems with the vaccination plan or the COVID response are not related to medicine, they are related to political-economic crisis. We have depletion of medical supplies, we have exodus of healthcare workers. We are now just conducting vaccine effectiveness studies. Nothing is out. We are planning a large study. Epidemiological data is still missing in Lebanon, and we know that we have documented the presence of several variants in the country. However, the positive aspects are quite numerous. We know that in Lebanon, the public sector and the private sector have a very strong partnership, and this partnership had paid very well, and we have dedicated staff that are committed despite what you call low assets. And so we hope that we can overcome the current situation. So finally, my take-home message to you is that despite the seriousness of the COVID pandemic, and despite the fact that many better-to-do global health systems and national health systems have failed to face the challenge of COVID, yet we know that Lebanon response to COVID exceeded our expectations. Our vaccination initiative is made in Lebanon. Our partnership between the private and the public sector is very crucial for the Lebanese success. But you have to remember that our healthcare system is on the verge of total collapse because of the lack of assets. And we are now supposedly living on survival mode. And this is why we need more collaboration between the academic centers in Lebanon. And definitely we would welcome any partnership or sistership between our medical centers, academic centers, and centers from abroad. They can really help our medical centers in order to sustain these austere times and severe times. Thank you. I hope I didn't take much of your time in this presentation. I will stop sharing and give the floor to somebody else.
I thank you very much, Dr. Bizri. Lebanon, with its tough economic and multiple other hurdles that are present, has done a tremendous job in trying to vaccinate the population, and in particular with regards to the economic situation. I want to turn our attention now to our international speakers, and I'm honored to have with us Dr. Nadine Raphael from the Emory Vaccine Center, Emory University, Atlanta, USA. Dr. Raphael is a physician scientist with expertise in all phases of clinical trials for vaccine, diagnostic, device, and antimicrobial resistance. Over the last 12 years, she has served as the national chair or co-chair, as well as lead PI or site PI of 50 protocols, and as a co-investigator for more than 130 trials, addressing a variety of infectious disease priorities in diverse populations. Nadine will be speaking on booster third shot vaccine and updates on COVID vaccine. Dr. Raphael.
Thank you, Dr. Ahmed. Masa al-khair. I'm really honored to be here and would like to thank the organizers for inviting me. Thank you so much for what everybody's doing there as a healthcare provider despite incredibly challenging times. Thank you, Professor Bizri, in particular, for bringing the vaccine to Lebanon. So I am an infectious disease physician by training, a clinical trialist by passion, and I did a lot of COVID over the past few months. So I do work with a team of scientists and staff here at the Hope Clinic, which is the clinical arm of the Emory Vaccine Center, with our mission in addressing global public health threats by translating basic research discoveries into clinical advance. And we do this by partnering with the community by conducting translational studies and interventional research, and also training the next generation of vaccinologists. We had, over the past just 4 years, had 10 physicians from Lebanon joining us in a postdoc opportunity here at the Hope Clinic. We are sponsored by many federal and state agencies through mostly the National Institute of Health grants and contracts. And this actually brings me to my conflict of interest. I served as the principal investigator for the Moderna phase 1 at Emory. We were the second site in the world to test a vaccine here in Atlanta, Georgia. And I also serve as the international chair for the Sanofi Pasteur phase 2 and phase 3. So it's not a if, but it's when pandemics would occur. And in the history of pandemics, some had very profound effects from the bubonic plague in the 14th century that killed 1/4 of Europe, to the influenza pandemic of 1918 that killed over 50 million people. And then obviously the most recent HIV/AIDS pandemic that had killed more than 30 million. And right now COVID, where we lost the lives of 5 million people, and we had many millions that had the disease and are suffering from long COVID. So the main pharmaceutical countermeasure against the pandemic is vaccine. The first generation vaccine have focused on the spike protein that allows the virus to latch to our human cells. Antibodies against the spike will avoid that dangerous liaison, but other components of the immune system do play an important role as well. So there are many ways a vaccine is made. Basically, the classical way is to take the virus and inactivate it. That's what some Chinese vaccine products that are available. This is not used in the US because of the theoretical risk of enhancing disease. So the focus had been on making the S protein, either coupling it with the adjuvant, so a protein adjuvant approach, or actually using novel technology that will include mRNA coding or viral vector DNA coding that will give the genetic code to our body to be able to produce the S protein and ultimately mount an immune response against this important protein. So while some vaccines are still in development, many have been approved in different countries since last year. And here in the US in particular, Pfizer has received full FDA approval in the summer. So we only have 3 vaccines here that are available in the US, which is Pfizer, Moderna, and Johnson & Johnson. And I will go back. This is basically the slide that we had before boosters got approved recently. The death toll in the US is close to 750,000. Now we have 220 million in the US that had received at least 1 dose, and 190 million that are considered fully immunized, with 12 million that have received an extra shot since August, when the FDA ACIP approved a 3rd shot only for immunocompromised. And we started giving an additional dose of Pfizer-BioNTech in September for selected individual. And just as of end of October, there was an additional dose of Moderna and J&J also for selected individual. And this is paying off, as you can see, particularly with the F curve. So first, the vaccine that had been most commonly given in the US had been nucleic acid vaccine. They're safe, they're very easy to develop in a sense that within 6 weeks, we had a vaccine that was ready to be tested in humans. So this was the Moderna NIH collaboration. And really they had the sequence posted online early January, and the vaccine was given to humans by mid-March, which is an astonishing speed of development. So as I mentioned before, Emory was one of the first sites to test this vaccine that ultimately led to a phase 3 trial 6 months later. Those are the results of the phase 3 trial. So more than 30,000 participants were enrolled across 99 US sites, and Emory we enrolled around 700 participants with great success in enrolling minorities. The vaccine was well tolerated. Pain was the most common local side effects, and in certain participants, severe systemic reactogenicity were noted, especially after the second vaccine, mainly headache, fatigue, myalgia, and arthralgia, but all were self-limited. What I want to show is Well, this point estimate had changed over time. So with the original publication, with the median follow-up of 2 months, it was 93%. But what's really interesting is you can see a split between the curve of the vaccine and the placebo just around 2 weeks from the first dose, where we barely have actually neutralizing antibody. And that separation is actually seen not only with the Moderna product, but also with the other product. This one had received a emergency use authorization by FDA in December of 2020. So very similar results with Pfizer in their phase 3. The vaccine is now recommended for 12 plus, and again, as I mentioned earlier, has full FDA approval. The next platform that I will focus on is the vector vaccine platform. So a virus such as measles or adenovirus is genetically engineered, so it can produce coronavirus protein in the body. So these viruses are typically weakened, so they cannot cause disease. We have 2 types, those that can replicate within the cells and those that cannot, because they don't have key genes that are essential for viral replication. The importance of the viral vector, though, that might not induce as high of an antibody response as the mRNA counterpart, is the fact that they are able to induce a great T cell responses, another way to clear the virus once we're infected. For example, there are some viral vectors such as VSV, which is approved for Ebola, that did not move forward. So really the one that had moved forward had been the adenovirus vector, either with J&J or AstraZeneca outside the US. So this is a trial that had been conducted internationally. Also at Emory, we were a site. The vaccine efficacy was 72% in the US and 66% worldwide. And then what the nice thing is this is a single dose vaccine, so that can help the most vulnerable population. It also had great protection against severe disease, 100% protection against hospitalization and death, and really kind of stood the test of the variant as the Beta strain was then circulating, particularly in South Africa. This is just also to show the local and the systemic reactogenicity, comparing the AD6 vaccine to placebo. Those were the early side effects that were noted in the pivotal phase 3 trials for the 3 vaccines that approved in the US. When this vaccine had been given to millions of billions of people, we start seeing more allergic reaction, particularly anaphylaxis with the mRNA vectors, myopericarditis, especially in young male receiving mRNA products, Guillain-Barré syndrome, which had been seen mostly with the J&J vector, and vaccine-induced immune thrombotic thrombocytopenia that had been seen either with the AstraZeneca or with J&J, particularly in rather younger female of childbearing potential. I mean, to keep this into perspective, we know for sure that thrombocytopenia, venous or arterial thromboembolism, strokes, myocardial infarction had all been seen to a much, much higher extent with the COVID virus itself compared to the shots. So then the big question, how durable is the protection, and can those vaccines that we had received earlier during the year protect us against the variants? So it's known to everybody that the virus does mutate and will continue to mutate over time. There are many variants of concern. This is a table that was made by one of our infectious disease fellows that illustrate well the different vaccines of concern and their impact on transmission, disease severity, and potential escape from vaccine or monoclonal antibodies. So the B117, that's the alpha, first reported in the UK, where lots of sequencing is being done there. It's more transmissible, more dangerous. P1, first identified in Brazil, perhaps the least concerning for any resistance to vaccination. The Beta strain that was first identified in South Africa by the end of 2020, that was quite concerning because probably it has the highest resistance to vaccines, still as partial resistance, and had made the AstraZeneca efficacy drop to only 20% and the Novavax efficacy dropped to 50% when these vaccines were tested in South Africa. And of course, the so well-known Delta strain, that's the predominant strain worldwide, with concern for more transmissibility and then severe disease. So I want to show you a paper that we had just last summer in Science, we were looking at those individuals from the phase 1 Moderna trial and how did they do over time, and what was the antibody response to the vaccines. Here you see them in white and black that were contained, to the strain that were contained in the vaccine compared to those that were circulating. And as you can see, the poorest response is for the beta strain in red, and then to some extent to the delta strain. But then to the others, it did decrease over time, but the decrease was not drastic, especially if it was against the strains that's contained in the vaccine. Well, should we be concerned then about the decay of antibody that we're observing in many studies? So everybody talks about antibodies being the correlates of protection. This is a publication from the Coronavirus Prevention Network from Dr. Peter Gilbert. The higher the antibody, the better the protection. However, if you look carefully, here it's at day 100 for the Moderna phase 3 trial, 50% protection is there, even if there is no detectable functional antibody, suggesting that other elements of the immune response that are contributing to protection. We have a lot of real-life data. I will show just a few. Here in blue is the vaccine effectiveness against infection, and in red against hospitalization. As you can see, the effectiveness against infection does decrease over time, perhaps a little bit more for Pfizer compared to Moderna, but nothing too drastic. But however, for hospitalization, it does remain rather intact, especially for people that have underlying medical condition. This perhaps is not fully the case for older people. Here we see it a bit differently, divided by vaccine, divided by either it's healthcare worker or nursing home resident. And as you can see with infection, we see that decrease over time, especially in the summer when Delta starts circulating in the US. We don't see it as much with hospitalization. So that's an important point to note, that the vaccine, even 6 months after the primary series, can provide excellent protection against hospitalization, 80% plus. So do we need a boost, and then which one? I think the answer is already there, at least from CDC and FDA, that we do need a vaccine. But to keep things into perspective, this is the number needed to vaccinate to prevent 1 hospitalization over 6 months, booster versus primary series that showed here in green. So as you can see, if a country has to decide between public health policy focusing on booster versus primary series, I mean, primary series always wins, especially for the older population. This is also the number of people needed to vaccinate with a booster dose to prevent 1 hospitalization. So as you can see, the benefit is much, much larger, especially for the adenovirus vector compared to mRNA, and especially if you are older, 65 plus in particular. This is a study that was done looking at the vaccine effectiveness of a 3rd dose of Pfizer-BioNTech. This is the factor reduction in confirmed infection rate. So as a whole, the absolute number is very low. But if you look at it from a factor reduction perspective, you can really start seeing a reduction with a 3rd dose, especially 12 days after the boost, which is typical when we start seeing an increase in antibody levels. This is a paper that was recently submitted to New England Journal of Medicine, looking at a mix and match approach. So the top panel is the IgG binding antibody, and then the lower panel is the neutralizing antibody, so quantity versus quality. And then you can see the boost was done either with the mRNA 1273, with the Ad26, or with the Pfizer-BioNTech, either in people that had received the Ad26, the Moderna, or the Pfizer-BioNTech at least 4 months prior. You can see perhaps always a similar trend with a marked increase in antibody response, either quantitatively or qualitatively, perhaps a little bit less if the boost is being done with Ad26. But in all fairness, for the adenovirus vector, we continue to see an increase in antibody levels over time. So perhaps sampling 2 to 4 weeks after a boost was not fair to to J&J. So right now the recommendations are following receipt of a mRNA primary series should receive a single mRNA COVID-19 vaccine boost if 6 months had passed from the completion of the primary series, if you're 65 years in age and above, 18 years and residing in a long-term care setting, age 50 to 64 with certain underlying medical condition that puts you at risk for severe COVID. The following recipients of mRNA primary series may receive a single mRNA COVID-19 vaccine, again, if 6 months had passed after the completion of the primary series. And this is, again, based on individual risk and benefit. I mean, I get this question all the time, should I get the boost? So we start talking more about, risk and benefits of each vaccine dose and how much SARS-CoV-2 is circulating in the community. So this applies to people 18 to 49 with certain underlying medical conditions, 18 to 64 at increased risk of SARS-CoV-2 exposure and transmission because of occupation and institution and setting. This is particularly the case for healthcare professionals. A mix and match approach is acceptable, though the recommendation from CDC had been to use the same product that was used for the primary regimen, though they did take into consideration the data that I just showed you and that was presented to them a couple of weeks ago. So this is actually how it's unfolding in the US. So currently for Pfizer-BioNTech, 30 micrograms separated by 21 days for anybody 12 years and above is recommended. An additional dose is given to immunocompromised at least more than 4 weeks after completing the primary series. And then a booster dose is given to immunocompetent individual, as I mentioned before, the one that should receive it and the one that may receive it. However, this is not recommended for 12 plus, it's recommended for 18 plus, mostly because of the concern of myopericarditis in male that are between 12 and 30. For Moderna, the primary series had been 100 micrograms, separated by 4 weeks. Immunocompromised receive also 100 micrograms, at least 4 weeks after completing the primary series. For the booster dose, it's a bit different. As far as dosing, it's recommended half a dose, which is 50 micrograms, at least 6 months after the completion of the primary series. And in people that are 18 plus, Moderna has not been able to secure approval for the pediatric indication. Sorry. For the J&J product, it's 5 to 10 to 10 virus particle as a single dose. They also recommend for immunocompromised and immunocompetent a second dose, that's the same dosing, at least 2 months from completing the first one. And it's only approved in adults and not in pediatrics. This is the work of many talented individuals that I work with. This is the great team with the multiple postdocs that we have from Lebanon. This is a picture where it was taken end of March, where we were giving the first vaccine in Georgia to a phase 1 Moderna recipient. And we have also an 80-year-old who was part of the Princess Diamond cruise. We were also testing the antibody to better understand the natural immune response and how we can build on that and develop vaccines for acquired immunity. Those are my 2 kids. They were brave to sign up for the Pfizer phase 3 pediatric study, and we're eagerly awaiting the CDC vote today in a couple of hours that hopefully will grant 5 to 11 years old the right to get vaccinated. So many thanks again. It's a pleasure to be here, and kudos to everything you're doing in Lebanon, and thank you for taking care of our parents and families and friends there.
Dean, thank you for an excellent talk and on such an important topic. I'd like to introduce our next guest speaker, Professor Esper Callas. He is from the Infectious Disease and Parasitic Department, School of Medicine, Sao Paulo, Brazil. Professor Esper is an infectious disease specialist and has been involved in several studies on HIV prevention, vaccine development and treatment. He is also conducting research projects on COVID-19, including evaluating treatment candidates, as well as the CoronaVac phase 3 clinical trial, which has led to its approval in a number of countries. Professor Callas will now present on new COVID pills and monoclonal antibody therapy. Professor Callas.
Thank you, Walid. It's a pleasure to be here. Assalamu alaikum al-kul. Proudly speaking on behalf of my family, who is from Feki in the Bekaa Valley. So it's a pleasure to be with you. And my goal today is go over quickly over the antiviral treatment, especially the antiviral pills and monoclonal antibodies. Just put this slide. So one thing that I would like to bring up to the discussion is the fact that where is the virus replication phase and when is it during the COVID-19 disease course? And I would like to call your attention that we have a window of opportunity to treat COVID-19 with antivirals that's basically restricted to the early course of disease. So any other strategies using antivirals that go beyond that period is deemed to fail because basically what we need is to cut viral replication in the early course of the disease. And this is a key importance because if you look back in time and we saw what happened with the behavior of PCR tests in COVID-19 patients, we were lured somehow by the isolation or the identification of SARS-CoV-2 RNA that span all the way through, on the average, 3.5 weeks after onset of symptoms, which was taken by many that the virus was still playing an important role in the late phases of the disease. But time has shown us that the virus replication is concentrated basically in the first few days after the onset of symptoms and doesn't go beyond 9 days after onset of symptoms. Therefore, the earlier you use an antiviral, the better would be the outcome. So that was part of some of the early failures that we saw in antiviral treatment for COVID-19. Now, what we need is to bring up with a strategy that would cut the ability of the virus to replicate in the cell cycle. So there are several products out there. Some of them block the virus outside the cell, such as monoclonal antibodies. Some block the replication of the RNA by interfering with the RNA-dependent RNA polymerase. And some of them interfere with the proteases of SARS-CoV-2. So these are the most prominent candidates to be used, and some of them have found its way into the clinical practice. So let me start with the antivirals, like full-fledged antivirals. So we have, I split in two categories here. The repositioning antivirals, some of them have shown some effect in vitro, and when brought to the clinic, many of them have failed. So just to mention that chloroquine and hydroxychloroquine have used much of our resources. The more than 300 clinical trials were performed with these drugs, and we could not find that was effective in treating COVID-19. Ivermectin, we still lack a large phase 3 clinical trial, but overall, most of its performance did not shown any effect in treating the disease. And finally, azithromycin, used by pulmonary physicians to treat chronic inflammation in some conditions, have also shown no effect. So I have those in red here that were basically discarded. But still, in some countries, including mine, there is a push to use these drugs, and it's very hard to go over political debacle to try to convince the authorities and some people in the community to stop using these drugs. There are two that are still pending the results, nitazoxanide and niclosamide, but these are just phase 1 or phase 2 clinical trials, so we need to wait a little bit more. So I will concentrate on new agents, remdesivir, molnupiravir, favipiravir, and 2 candidate drugs that are in the clinical development in a more advanced stage. So let me start with remdesivir. Now it has a brand name called Vicluri. And there are 2 main trials that I would like to call your attention. The first one is the ACT study, was published the final and consolidated results in December 2020, have shown a modest effect in decrease in the progression of the disease. And what caught our attention in this trial is the fact that this drug, although decreased the length of stay in the hospital, did not cut short the percentage of people dying of the disease. It was heavily criticized, nevertheless obtained, when the primary results came out, emergency use authorization in the United States and several countries. Now, the largest trial is the WHO Solidarity Trial Consortium, treating hospitalized patients with no effect. But now we have accumulating results from real-world trials that point to some efficacy, varying from 23 to 54% when you use in early stages of the disease in hospitalized patients. Just call your attention that all these trials are performed in partnership with the manufacturer Gilead. So I think we're still waiting for those final results to come out. And because the results with this drug are conflicting, although they have been part of the standard of care in many countries. Now, molnupiravir is an oral drug developed by Ridgeback Pharmaceuticals and put into clinical development by Merck. The phase 2 clinical trial have shown a remarkable effect in decreasing the virus load in the respiratory tract. In the phase 3 clinical trial, early results came out. They plan to enroll 1,550 individuals in the phase 3 clinical trial. Some of us here participating in this call have participated in this trial. And this Move Out study has been stopped about a month and a half ago when they announced the primary results that reduced the risk of hospitalization in 50%. Just bear in mind with me that from these individuals treated with this drug, no deaths, whereas the placebo arm, they were able to document 8 people who died of COVID-19. So it's promising. We're still waiting for the granularity of those results to make a better judgment. Who are the candidates to receive this oral drug, which would be a great choice to treat individuals at early phase out of the diagnosis of COVID-19. We also have a favipiravir, a drug that was early developed to treat influenza, but the name is Avigan, has some antiviral activity, but when you compare it to other drugs, it's not very heavily considered as a strong, potent antiviral. Nevertheless, was able to decrease the number of days of virus shedding in those individuals with COVID-19, comparing those who are in the favipiravir group was 62.5%. A clearance of virus comparing to 30% in a small study carried out in Asia. Now there is a phase 3 clinical trials ongoing, the Priseco and Pepco. So Priseco is for treatment of early disease, same sort of design as the Merck pill phase 3 drug. And the Pepco is the trial for post-exposure prophylaxis. We're still waiting for those results. Finally, these 2 drugs, the PF 073-21332 is a drug developed by Pfizer. It's basically a protease inhibitor, and it's co-administered with low-dose ritonavir, which is a inhibitor of cytokine P enzyme 3A4 to increase the half-life of this drug. So the phase 3 clinical trial called EPIC-PEP is on its way. It was launched very recently. The press release from Pfizer came on September 27, announcing that that study is ongoing. And the Atea drug, called it AT527, is a purine oral analog, nucleotide analog, and it's designed to inhibit RNA polymerase enzyme and have shown to decrease the virus load in those treated individuals. Phase 3 clinical trial is ongoing. Now let me switch gears here to the use of antibodies. So the first attempt was convalescent plasma. It's obtained from individuals who were recovered from COVID-19 and infused either for prophylaxis or therapy, but basically most of the studies are in therapy. So it was early approved in August 23 under a lot of criticism in the United States based on preliminary results from a consortium using convalescent plasma to treat in the United States COVID-19 patients. Now, the meta-analysis in hospitalized patients, most of these studies done in severe cases have shown no effect in all-cause mortality, but also in length of hospital stay and the use of ventilators. So for those severe cases, basically the bulk of the data by and large have shown that there is no effect in treating the disease. Nevertheless, there was the January study by Joyner and colleagues, and here you may recognize that Arturo Casadeval, who is a big enthusiast of convalescent plasma in treating COVID-19, have shown that when you treat those individuals with high titers of convalescent plasma, there is a lower level of deaths compared to low level of neutralizing antibodies in the plasma that's been given to these individuals. Nevertheless, the effect, as you can see, is modest, but was there was a surprising result that came out in January this year by the Argentinian group led by Libster. Basically, what they did was to give the convalescent plasma up to 3 days after onset of symptoms, with a remarkable result, decreasing the development of disease progression in 73.3%, pretty remarkable. But a few weeks ago, there was the Corley paper in the New England Journal of Medicine that used that strategy in a much larger number of patients with no observed significant effect. So there's a lot of criticism and debate whether the definition of the disease was appropriate for this paper, several letters to the New England Journal of Medicine. But what we can take out of this is basically neutralizing antibodies in convalescent plasma are probably at the lower levels and lower potency than what we need to treat the disease if you compare with neutralizing monoclonal antibodies. So basically here you identify the monoclonal antibody that's highly potent, you produce in high throughput companies, and you can have a lot of these antibodies infused either in isolation or in combination, what we call cocktails, to treat the disease. So the first one that was famous was the Regeneron cocktail with 2 monoclonal antibodies that was given to the ex-president, the former president of the United States, Donald Trump. That happened in October when he got sick, and that was got a lot of attention by the media and the public. But basically, there are several monoclonal antibodies under development. Here I list the phase 1 clinical trials in several of these products by many companies around the world. Some of them are in the verge of completion. These are the phase 1/2 clinical trials underway. See, there's a lot of companies developing these products. In the phase 3 clinical trials, we have 8 of them underway as we speak. So there's a lot of enthusiasm about this strategy. And because 4 of them got emergency use authorization for treatment. We have the Celltrion, the Korean company that obtained emergency use authorization in Korea, and 3 others received emergency use authorization in the United States and several European countries. And all of these 4 were approved to be used in emergency use basis here in Brazil as well. So we have the Vir and Glaxo. It's a single monoclonal antibody. It's a very promising drug to be used because it acts against all the variants up until now. The Absalera Eli Lilly that had some caveats in the bemnifosbuvir monoclonal antibody was not as efficient in neutralizing the Delta variant, but the cocktail is. And finally, the Regeneron antibody. There is a very large pipeline in using those monoclonal antibodies in treating the disease. So what we saw in out of all of these trials, that the decreased progression of the disease if used in early phase of the disease in about 80%. So with that, I think this is changing the landscape to treat COVID-19. And as these products come on board, probably gonna help us in controlling the disease much better. So we have several of them that received emergency use authorization since November 2020 and now in May 2021 when the Vir Glaxo monoclonal antibody was approved. And finally, just to wrap up, I'd like to call your attention to the effort in the community in the race for the super antibody against COVID-19. Not only that, but also antibodies that could treat other coronaviruses, because we need to be prepared for next pandemics. I would like to thank the organizers, especially our group here working in clinical trials for the development of novel treatment of COVID-19. And thank you again for the invitation to present at this venue. With that, I'll finalize and get back to Walid.
Thank you very much, Professor Callas, for an excellent presentation. We come to our final speaker, Dr. Samar Ajami, who is a clinical immunologist and infectious disease physician at Monash Medical Centre here in Melbourne, Australia. Her research background includes a PhD in Mycobacterium tuberculosis. She currently leads the Diagnostic Immunology Laboratory at Monash Health, Melbourne, Australia. Her clinical interests include inborn error of immunity. Dr. Ajami will now speak on COVID anti-cytokine therapeutic recommendations. Samar?
Thanks, Walid. Thanks for asking me to talk today. Apologies if I might sound slurred. It is 5 o'clock this morning over in Australia. Firstly, I just wanted to start also by saying well done to you all on working in such difficult circumstances. We've been quite blessed in Australia in that we have mostly weathered the storm of COVID pretty well up until about 4 months ago, but our vaccination rates have hit 80% double vaccinated, and we're heading towards 95% potentially. So hopefully it does sadden me that there's so much inequity around the world, and I hope things do improve in Lebanon. So this is not new to everybody, but essentially the SARS-CoV virus is a respiratory virus that does enter our body through its binding of the spike protein on its surface into our own lung pneumocytes, and essentially then induces a lung infection and an immune response. And what I wanted to concentrate mostly on today is the immune response. And what we see with the infection itself is quite a wide spectrum of infections. And most people potentially asymptomatic or have very mild symptoms and fully recover, especially in children. And as we now also know, vaccinated are protected from severe disease. We have the extreme of the spectrum, and that's the severe illness, where essentially people can get AIDS and ultimately die. And the risk factors for these are old age, being male gender, having chronic disease, including diabetes, obesity, and high blood pressure. But we're also, due to the learning that we are seeing with COVID, we are learning more and more about underlying immune mechanisms and defects and inborn errors of immunity that predispose to severe COVID, but also antibodies, including interferon alpha antibodies that we're seeing in a large percentage of the population that are predisposing to severe disease. The unvaccinated, as well as we're seeing severe disease, particularly with the Delta strain in pregnant women. Now, what has become quite clear is that the immune system plays a massive role in the disease and severe disease. From very, very early on, it became clear that people who were presenting to hospitals and requiring ICUs had an inflammatory spectrum of disease. They tended to have lower lymphocytes and high neutrophils, high D dimers, high LDH, and they tended to have multi-organ dysfunction and elevated inflammatory markers, including CRP and interleukin-6. And very much in that context, it pointed to what behaved like a cytokine release syndrome from very, very early on. And just touching on that, normally when we fight a virus, what happens is our innate immune system picks it up, notices it as a foreign organism, produces cytokines that are there to alarm, but not to cause too much damage. And then via communication to our cytotoxic lymphocytes, we either induce cell death of the infected cell or induce adaptive immunity by T cells then working with our B cells to induce an antibody response. Now, with COVID, what we know is that there's actually a delay in T cell responses, and what happens is that there's actually an increase in the cytokines that do release and increase in the monocytic processes that do happen. So what happens is a number of different cascade of immune mechanisms that essentially drive severe disease, including complement activation, which produces some of the issues that we see, and myeloid cell recruitment, which drive more of the cytokine storms, and becomes a vicious cycle essentially. We see recruitments of neutrophils, and through the neutrophils, they produce nets, and that drives some of the thrombosis and inflammation also that we tend to see. And the interleukin-6 is certainly raised, and some of the fibrosis and all of that essentially that ensues following all of these cytokine storms. And so what happens is that you do get an AIDS type picture. With that, you can, the patient with a cytokine storm can lead to multi-organ dysfunction, including some of the things that we see, such as strokes, hepatitis, liver dysfunction, as well as the myocarditis and pericarditis that can be seen, as well as some of the clotting as well issues. And so really severe COVID is a crossroad between an adequate and overactive immune response. And thankfully, this was realized quite early on, and hence why immunomodulators were from the get-go really used and extensively, and quite a large number of immune modulators have been used. And as already mentioned, hydrochloroquine and azithromycin were used very, very early on as well, and haven't been shown to really help very much at all. So this diagram highlights a lot of those that have been used to try and modulate some of the immune response. However, in practice, not all of them have been shown to be helpful. And what I'm going to focus on today are essentially the ones that we use here in Australia. And we're guided by our national COVID task force that basically puts the evidence all together and guides us into what we should use. So it was very early on that it was initially the talk was don't use corticosteroids because they can cause more damage. But then it was very early on in June when it was actually realized that they do have a role. And the recovery trial was one of the first to show this. And basically, corticosteroids work in a number of ways. But one of the ways is that it does reduce macrophage activation as well as T cell activation, works directly to reduce the cytokine storm. It has anti-swelling properties, which are quite helpful in the context of an AIDS, as well as reduction of fibrosis as well, which is important in the long-term complications of COVID. Now, the dose that's recommended is dexamethasone 6 milligrams daily up to 10 days, or the equivalent dosing in the absence of dexamethasone. What did become quite clear is that dexamethasone was helpful in reducing all-cause mortality and invasive mechanical ventilation need or death. However, what also became quite quickly noticeable is that if it was used in people who were not requiring oxygen, then it could potentially have detrimental effect. So the recommendation for dexamethasone is to only use it in the context of patients requiring oxygen. With improvements also to discharge from hospital. Now, in the case of tocilizumab or interleukin-6 targets, the story with the tocilizumab really began very, very early on from reports from China, being very small cohort case studies that were published. And really the tocilizumab story was an extension of the CAR T cell cytokine release syndrome. And it's used in that context where it's very, very helpful. And so very early on it was used and there was anecdotal evidence that it was helpful, but then studies were quite conflicting, some showing response, some showing lack of response. But it was two big trials, the REMAP-CAP trial and the recovery trials, that did eventually show that there was an improvement. And I guess it's not surprising given the role that interleukin-6 plays and the abundance of interleukin-6 within COVID patients, particularly severe disease patients. Interleukin-6 has a widespread role in immunity. It recruits, it helps T cells differentiate into Th17 cells, which then recruit neutrophils, which we know are part of the pathogenesis of COVID. It has a role in angiogenesis and clotting factors, and there was some neovascularization that was seen in some COVID patients as well. And so it had quite a widespread use. And so it's no surprise that tocilizumab has made it into the fold of it being quite a helpful medication. The difficulty though with tocilizumab is that unfortunately there is a worldwide shortage because of its widespread use. Here in Australia, we reserve tocilizumab mostly for our pregnant patients as well as our children. We don't have seralutinib available. However, that's another option in the absence of tocilizumab. And tocilizumab has been shown to be helpful in reducing all-cause mortality, AIDS, as well as admission to intensive care and increasing discharge from hospital. Meanwhile, JAK inhibitors, again, very early on in the context of the cytokine storm and what was being realized around the interferon story as well, is that they became quite a popular option to look into at least. But the basis is that cytokines are drivers of a lot of our cellular processes, and by binding to its receptor, cytokines then initiate JAK phosphorylation of STATs, and so some of the processes including interferon binding and signaling, as well as GM-CSF, which is a driver of monocytes as well. So there were quite a number of cellular mechanisms where cytokine signaling is quite important, and in that context, they were trialed. And 2 large studies basically have shown that Jakafi can be a really helpful drug in the context of COVID hospitalized patients, including the ACT-2 trial as well as the Cove Barrier study. And where it works, so by in vitro, it was shown that baricitinib might potentially block SARS-CoV entry into the cells, as well as inhibiting not only interleukin-6 signaling, but also neutrophil recruitment, as TNF signaling, as well as GCSF signaling, and interferon gamma signaling. So being that switch to an activated immune system. And as I already mentioned, by that time, it wasn't so much the virus itself that was causing the issue, but rather the immune system itself that was driving. And so helping settle it down and allowing for the T cell responses to really kick in would be important. And baricitinib has some of the most impressive, I guess, out of the immunomodulators in terms of efficacy. It results in 45 fewer per 1,000 reduction in death, as well as it reduces the need for invasive mechanical ventilation, as well as improvement in clinical recovery, with very little difference in adverse events, actually. So it seems to be quite safe and well tolerated. And the recommendation with Barry is dependent on kidney function in terms of dosing, but generally for adults about 4 milligrams, starting up to 14 days. However, we tend to, it seems to switch things off, and you can seize it sooner than the 14 days. And so far as we know, there's no world shortage of baricitinib, though I'm not sure what access is like in Lebanon. And so most of the guidelines really around the world, this is the NIH guideline, which you can access online, as well as the UK guidelines, the NICE guidelines, and really most places now generally would recommend, depending on the severity of illness, of what to do, but for those requiring oxygen, at minimum dexamethasone. We can argue about the addition of remdesivir. However, dexamethasone is a very important addition. In those, if any signs of inflammation, then the recommendation is to add an anti-inflammatory. We have been favouring baricitinib. I personally favour it just because of the fact that it's more than interleukin-6 that's causing damage. And I think from a biological basis, it probably is the better drug, but also due to the shortage as well. Now, initially, baricitinib was considered not for use in those who are mechanically ventilated. However, there is some recent data coming out, hopefully soon, that was presented in ID Week to suggest that actually that population also significantly benefits from the use of baricitinib, even in that context. So this is what we do here in our centre at Monash. So we stratify according to risk, and for our mild patients who are presenting early on, we do arrange for budesonide to reach them in their home, as well as for those high risk, we do give them stropimab. We've set up a clinic where they come in, they get the infusion, and they go home if they fit the criteria. And in those with moderate disease requiring admission, those requiring oxygen do end up with dexamethasone. We do generally kind of leave it as a stepwise progress, although a lot of the time the patients are, rather than wait for them to deteriorate further, we do give baricitinib quite early on as well. Now, in the context of pregnancy, there certainly is a large need for it, with pregnant women doing, particularly in the 3rd trimester, having a less favourable outcome with COVID. However, they do have limited options, mostly because unfortunately many pregnant women are excluded from studies. What we tend to use is dexamethasone with tocilizumab. Baricitinib really has very little data in pregnancy, and for that reason, we reserve toci for this population. And similarly, In children, the general recommendation is dexamethasone and tocilizumab. However, we have comfortably been happy to use baricitinib as well in the right context. Now, the other use of these immunomodulatory medications is also in the context of MSC or multi-inflammatory post-infectious syndrome relating to COVID, otherwise also known as PIMS as well. Now, this is, as most of you would know, is generally a post-COVID syndrome that occurs mostly in children, although it has been reported also in adults. They tend to present about 4 to 6 weeks following their infection, and seem to present similarly to Kawasaki's with fever, sometimes mostly requiring oxygen and having some hemodynamic instability as well as a whole range of varied symptoms, including symptoms that could very much be fit Kawasaki. With quite raised inflammatory markers with multi-organ issues and especially cardiovascular effects as well. Generally for this group, we would use supportive care and give IVIG as well as consider methylprednisolone, although in our hands, most do seem to improve with the IVIG, though thankfully, as I mentioned, we've had very, very few cases here in Australia. And subsequently followed by anakinra tends to be the one that's generally used in this context. So having said that, we do have a number of options now compared to where we were at the start of the pandemic that have been shown to be helpful. However, really the best way is still to avoid getting COVID and avoid passing it on to those that are immunocompromised. And that's by following the general measures that we've been following for the last many months. But also vaccination, and I strongly encourage vaccination to try and avoid severe disease, as already seen in the data shown, very impressive data that's been shown, and including for those who have actually had COVID as well. And with that, I'll end it there and hopefully kept to time.
Thank you, Samar, for an excellent question. We do have for an excellent presentation. We do have a number of questions and would like to address some. I think the first one I'll ask probably Espa, because we've lost Nadine. But one of the questions that is asked is, if someone is fully vaccinated or has had the COVID infection, do they need another booster shot, Espa? I think we may, can I get Samar, would you like to answer that?
Sure. So this is someone who's had COVID and has been vaccinated. Sorry, is that right, Walid?
Yes, correct.
Yeah. So look, we don't really have enough data to say that the infection acts as a booster. We do know that people who have had COVID, who have had vaccine, show quite impressive response to the vaccination. So potentially it might be a booster, but I think the general recommendation is still to proceed with the booster.
Thank you for that. There's another question, if we've got Dr. Bizri with us. In a patient with a renal transplant who has had minimal anti-spike antibodies and had 2 doses of Pfizer, does that mean no immunity will be developed? It's a bit of a difficult question because I know Nadine's answered it in that the commercial testing of antibodies is not that strong at the moment. But Dr. Bizri, if you're with us.
Yeah, sure. I'm still. Let me tell you, we have faced this problem in Lebanon because most of our renal transplant patients did not really respond well to the 2 doses of Pfizer, given the commercial antibody testing we have. And we know from the literature that people who were poor responders or did not respond at all, even with the 3rd dose, the Pfizer dosage did not really mean much. So those who had really a partial response, they responded well. We are encouraging them to take a 3rd dose. However, we know that measuring only the antibody response by crude antibody method is probably an underestimation of that. So we believe that they have really taken some degree of immunity, but it may not be enough, and we encourage them to take a third booster dose. To do other tests to assess their immunity is possible, but it's going to be very expensive at this stage.
Thank you for that. I've got another question for you as well. It comes from within Lebanon, and this is directed at yourself, Dr. Bizri. The question is, it seems monoclonal antibodies and remdesivir are not available in Lebanon, and I doubt molnupiravir will be ordered. But they've just asked if, to correct it if they're wrong or not. Is that, can you update us on that?
Yeah, sure. Let me tell you, remdesivir is available in Lebanon. We had the small stock of remdesivir coming either as a donation from the Egyptian government or as directly from the company we bought it by what you call supported dollar. However, in Lebanon now we have a factory that produces remdesivir locally, and it's really a good product. So remdesivir is available. Favipiravir is also available. We have used it on 6,000 or 7,000 patients so far. The results are quite acceptable. They have really preventing people from going to hospitalization, even in a critically ill patient. Unfortunately, the data is not very well organized to express our experience, and molnupiravir unlikely to get it soon because of the what you call money restriction and the prevention of converging into money. So we are unlikely to get the monoclonal antibody or molnupiravir soon, but we have favipiravir and remdesivir available, as well as the Actemra, which just Summer has alluded to recently. We used to have it. Now it is really in very small amount, and we know that Roche had the difficulty in producing enough amounts for that. So these medications are available. Can I ask Summer a question, Dr. Ahmad?
Yes, go ahead.
Go ahead, please. In Lebanon, we tend to use methylprednisolone more than dexamethasone. We are more encouraged with the more recent experience. What do you think?
Yeah, look, I think any of the corticosteroids is good. I think dexamethasone is started having some more of the fluid effect and the mineral corticoid sort of effect. But I think any of the corticosteroids and equivalent in equivalent doses is actually pretty good at reducing that cytokine storm.
Thank you.
There's a very good question that's come up on Facebook from a listener. Do you rely on the measure of IL-6 to decide for TOSI or after dexamethasone, Summer? No, so look, interleukin-6 is not really available widely. In fact, we don't do it at our centre. It takes a long time for it to come back, and by the time it comes back, it's not helpful. And really, the interleukin-6, the final result of it is the CRP, so that's what we tend to use to monitor. And generally, we would not recommend use of these medications unless there is evidence of inflammation, and it's very rare to have these patients not have a high CRP, but we would reserve its use for those with a CRP that's greater than 75. Generally is what we do. Yes, thank you for that. There's another comment directed. There are conflicting reports with hydrochloroquine. There's some favoring and some others. I know from this talk, and it's been asked by one of our questions that have come up on chat, is it dispelled? Would you use it, or is completely out of the question, Dr. Bizri and Summer?
We let me tell you, in Lebanon, we stopped using it way before. However, many in our French school, because of the influence of some of the French physicians, are still using azithromycin in combination with the chloroquine. But in generally speaking, most of our infectious disease physicians and pulmonologists have stopped using it.
Yeah, just to add to that, there is a bulk of data suggesting that it doesn't provide you any benefit, any side effect could be harmful. So here is the primum non nocere principle which should be applied.
Thank you. For the last question that I would direct.
May I ask Samar a question, Dr. Walid?
Yeah, go ahead.
Go ahead. Samar, what about procalcitonin? What do you think is the value of procalcitonin?
So look, so procalcitonin is helpful to a degree. It is increased in the context of COVID, but it's the degree of increase that we rely on to help us work out whether someone could have a superimposed bacterial infection. It's very rare for these patients to actually, particularly at the early, at that day 7 mark where they present very inflammatory, for there to be a bacterial infection. But it's helpful, I guess, in that context, particularly when we are looking to use some of these immunosuppressive medications as well. So that's mostly where we use it, though overall I think treating the patient as you have in front of you, and if you don't have access to procalcitonin, I don't necessarily think it's a big loss.
Because our experience in Lebanon, mainly at AUB at American University, is that it correlated with the severity of disease rather than the bacterial infection.
Yes, and that's what most people are. That's what we find is that it is raised in COVID, and so in that context, it's not helpful except for the degree of the rise. Dr. Kalas might have more to say. They've treated a whole lot more COVID patients than we have, so might have more experience in terms of how helpful it is in their population.
You mean in procalcitonin?
Yes.
No, we did not use here, so I cannot share any experience on that drug, unfortunately.
There's another question I direct to you all. With the flu vaccination and COVID, do you still go ahead and have the flu vaccination? What's the experience in Lebanon, Brazil, and Australia? We'll go with you, Dr. Bizri, to start off with.
Last year, we did not really encounter any flu. This year, we are encountering more flu cases than we had all of last year. Unfortunately, the flu vaccine is not available because of what you call also banknotes and bank transfer reason. But we are encouraging all of our patients to take flu, and we know that the new recommendation allows the flu vaccine and the COVID vaccine to be given even simultaneously if need be. So we are not really, so we are encouraging all of our patients to take the flu vaccine, especially that we're seeing now an active flu disease, mainly in Lebanon so far, are flu A, H3 and 2 are almost all of our cases so far.
Espa, what's the situation in Brazil?
Yeah, so the reporting of influenza has dramatically dropped during this year and a half, and mirroring what we saw in the CDC data on influenza, we barely see cases of flu here at the moment. Now we're starting to see a few, but this leads to the notion that the non-pharmacological interventions to prevent COVID-19 has impacted in the flu transmission as well. Therefore, with the flexibility of these interventions, we expect a not so easy flu season coming ahead. So I think we should all be aware of that. Expanding vaccination against influenza is a good idea at this moment, and expanding also the ability to diagnose and treat influenza, I think, will be very important and advisable for the coming season.
Samar, our experience here in Australia?
Yeah, so our experience in Australia is that similar around the world. Flu last year was essentially non-existent. It started with a normal flu season, but we locked down pretty quickly and it just basically it stopped. However, we are expecting the flu season to get going, and we have been vaccinating. Even last year, we continued our vaccination program. With the concern also is that I guess it's maintaining that immunity, the cross immunity across strains as well. And I think that's one thing we are expecting is that as soon as we open up is potentially not just the flu, but also other viruses as well. I mean, we saw it when we in between lockdowns for us, and I'm sure around the world as well. But RSV was quite a nasty virus that we were seeing, particularly in our children. So we are certainly expecting the flu season to get going, and we are vaccinating. Our vaccine doesn't become available until end of March.
This last question, I've got to ask it because it's dear to my heart as a cardiologist. Question asked by Jolene: is it possible to develop heart inflammation 2 days after mRNA vaccine with negative troponin? Her partner's a 39-year-old male with asthma. Espo, would you like to answer that, or Samar or Dr. Bizzetti? Or I think you
see, most of the cases have occurred after the second dose rather than the first dose, most of the cases, and they occurred in adolescents and younger people. So 39 is young enough for that. The question whether the troponin should always be elevated or not is not really a very strong marker of that. Depends upon the severity of the inflammation. Maybe a follow-up troponin should be, but we have to keep that in mind as a possibility. We see it from day 1, 2 to till day 15 in most of the cases, but after the second dose.
Thank you for that, Dr. Bizzetti. I will now hand over now to Dr. Yusuf Bakhosh to finish this Zoom meeting. And I want to thank all the presenters for an excellent presentation, the caliber of the questions as well. Dr. Yusuf.
Thank you, Walid. I would like just to thank all the speakers for taking the time to participate and to share their experience and their researches on COVID-19, either vaccination or treatments. Also, I would like to thank all those who participated in the organization of this webinar, which was really informative, particularly the Lebanese Order of Physicians, the International Lebanese Medical Association, and the Lebanese Society of Infectious Disease. So before closing, I would like to give you a rendezvous in 3 weeks on Wednesday 24 for our second webinar. And if I can share my screen, just to show the leaflet of this webinar, which will be organized on Wednesday, 24 of November, on updates and innovations on otolaryngology, organized with the Lebanese Society of Otolaryngology, Head and Neck Surgery. So we are waiting to see you on the last week of November for our second webinar. So thank you and have a good night.